presenters.
Thank you, Claudio. I think I'll make a start. Hello, everyone. My name is Jolie. My pronouns are she, her, and I'm just going to share my screen for my presentation. I think that worked, but please someone give me a shout if it hasn't. Great. So yeah, today I'll be speaking about the study that I'm leading on called Circle, Creating Inclusive Residential Care for LGBTQ+ Elders. And as Claudio mentioned, joined by Martin Wells, so also represented on this slide here. I'll briefly talk you through the agenda, what I'm going to discuss. I'm going to talk a little bit about, in general, what is LGBTQ+ inclusive care and why it is important. And then the Circle project, what does it entail? We have 3 work packages, what we call them, which is basically 3 streams of work within the project. And I'll discuss each 3 of them and some of the preliminary findings because the project hasn't finished yet. And then I'll finish with some practice recommendations. And Martin will contribute to the session, to the part about the 3rd work package, but we'll come to that later. So what is LGBTQ+ inclusive care? When we talk about inclusive care, we mean care and access to care and resources that is equal and equitable to cisgender and heterosexual people. So that means to people who identify as heterosexual and people who identify as the gender that they were born, the sex they were born as. This is currently not always the case. Many LGBTQ+ people experience discrimination and barriers in access to care, so that access to care is currently not equal and equitable. Inclusive care also involves an environment in which people's differences in sexual orientation and gender identity are valued and celebrated rather than just tolerated. It's an environment where it's seen as something to celebrate. Inclusive care is also acknowledging that sexual orientation and gender identity are relevant to care needs. I speak to a lot of care providers as part of my work, and a lot of people say, but I don't need to know that it doesn't matter to me. And that comes from a good place. People mean well by saying that, but by saying that you also disregard that being part of minoritized sexual orientation or gender identity has consequences for the type and extent to which you have care needs. So it's very important to have care that's fully inclusive, that people are aware of this. It also involves facilitating full participation in the care environment. So, for example, that can range from really big topics like fully recognizing people's chosen families and partners, even if they look differently than heterosexual relationships that you're used to smaller things, but that make a big difference in people's day-to-day life, to, for example, the type of entertainment they have in a care home or in a care environment, or the type of magazines they can access. Inclusive care also includes an environment where discrimination and intolerance are addressed and eradicated, as opposed to ignored, for example, because it's too difficult or too awkward to address. So there are good policies in place that address and eradicate discrimination and intolerance. Why is it important that we focus on LGBTQ+ inclusive care? There are an estimated 1 million people in England and Wales who are over 60 and identify as LGBTQ+, and that's likely to be an underestimate because only recently did the census start collecting data on sexual orientation and gender identity. And you can also skip that question or say you prefer not to answer. And more people are more comfortable, thankfully, to disclose that they're LGBTQ+. But the people who are over 60 now and identify as LGBTQ+ have lived through many discriminatory policies and laws that really affect their confidence in public services, such as social care. And they've lived through things like the decriminalization of homosexuality and Section 28 and the armed forces policies, and only since we've been in this millennium have things like the Gender Recognition Act and Marriage Equality Act become into effect. So it's a very important context in which these people experience public services. This group also expects to rely more heavily on social care and healthcare because of specific health risks. They're, for example, more likely to live alone and have a lack of informal social support, which is often a result of, for example, families who are not accepting of LGBTQ plus identity. And because of that minority status of being LGBTQ plus, people experience increased minority stress, which then increases the likelihood for care needs. So it's really important that those care environments are prepared for that and see the relevance of LGBTQ plus identity and can support people. A lot of older LGBTQ plus people are concerned about the possibility of needing care, and they worry that they'll have to go back into the closet when they go into a care home, for example, and that they have to hide their identity, which is very, very sad. And on more than one occasion have people told me that they would rather die than move into a care environment because they're so worried about not being accepted, which is just not how it should be. Several recent reports from both research and the government also demonstrate that care services are currently lacking in their LGBTQ plus inclusive care provision. And that means both in terms of the type of care they provide, so how people experience it, but also the skills and the confidence that people have to provide inclusive care. A lot of people are willing, in my experience, but they just don't know where to start or how to go about it. And sexuality and gender, especially in old age, are still often seen as a sort of taboo subject. So this is where the Circle project comes in. It's a 2-year research study funded by the National Institute for Health and Care Research. And because it was clear that LGBTQ plus inclusive care is currently lacking in its provision, and it's important that we address that gap. This study really focused on how can providers be supported to provide LGBTQ plus inclusive care. So what are different ways to support care providers? And this study specifically focused on care homes, so residential care providers for older people. And there were 3 ways that we were evaluating, 3 ways of supporting providers. The first one was a comprehensive inclusion program. The second one was a community of practice. And the third one was a co-designed resource. And I'll go through each of them briefly. So this comprehensive inclusion program is a program that care homes went through, where it really holistically looked at different elements of the organization and assessed to what extent they were LGBTQ plus inclusive and provided recommendations for improvement. So this program, initially we were working together, the study was working together with Opening Doors, the large national charity supporting LGBTQ plus people over 50. But very sadly, they had to close in last February, which means that we can no longer use the terminology that they called this program, which was Pride in Care, but we've still been able to offer certain elements of it. But I just wanted to mention that because they were an important part of the project. So what we looked at were different marketing materials that the care homes had, so their website and brochures, their staff attitudes, their company policies and staff training. And this program was implemented in 4 care homes in Sussex. And with interviews and surveys, we examined before and after the program how people's skills and confidence were affected by the program in terms of how well they thought that they could provide LGBTQ plus inclusive care, but also their attitudes towards the LGBTQ plus community, and also looking at how well the program worked in a care home context. Because it's quite a specific context where staff are under a lot of pressure, and we wanted to know, does this program work well in that context? So the data collection is ongoing, but what we found so far is that the care homes that we were working with, the staff attitudes were predominantly positive towards the LGBTQ plus community, which I'm not completely surprised about. We had like the odd response of people that were negative, but I think the kind of homes that would engage with this work are homes that already have some sort of interest in this topic. So you're likely to get a bit of a bias there with homes that will probably rate more positively than the general sort of workforce. But there was still indication for further training needs, which we also provided. So it'll be interesting when we're currently in the process of collecting the sort of post-program data, whether that has affected the staff attitudes and confidence. The marketing materials were lacking in explicit imagery of LGBTQ plus community, which we've provided recommendations about, and the care homes are currently implementing these. So they are thinking about images on their websites, but also explicitly mentioning that they're committed to providing LGBTQ plus inclusive care, because for a lot of people, it's very important that after a lifetime of constantly wondering whether you're safe, that there's some explicit mentioning that, and this is the case. Policies were good overall, but there was a requirement for more detailed inclusion policies. So often what you see is that inclusion policies are very generalized and focus on equality, diversity, and inclusivity in general, rather than looking at the specific protected characteristics. And before the inclusion program, staff indicated that they thought their home had enough staff and resources to implement the program, but it will be interesting to see how they've experienced it afterwards, especially with the challenge that we've had with opening doors closing. That must have impacted on how they've experienced it. The second way that we're supporting providers is through a community of practice, which is a group of people who share a common concern or interest, and they come together regularly to work on shared learning and fulfill shared goals. The community of practice that we are running is an online one. So we organize meetings every quarter, roughly, so every 3 months. And it's a really sort of low threshold way where people can access. It's not really training, but I think people still experience it as training, because we talk about a certain aspect of LGBTQ plus inclusion in each session. It's free to attend, and we try to make it really interactive, so it's not the lecture that people attend. But depending on your level of comfort, you can attend and just listen in, or you can join in more in the discussions. We've had 6 meetings so far, and there's a little bit of a break now, but we're hoping to continue next spring. So even though the project is ending, I'm hoping to keep this community of practice going, because we collected online survey data after the 3rd and the 6th meeting, to see how people experience the community of practice meetings, if they found it useful, if they feel like it's improved their skills and confidence. And we had very positive results, and people, a large majority, over 90%, indicate that they would like meetings to continue. I just wanted to give a little bit of an insight into the type of impact that people have mentioned because of attending the community of practice meetings. Someone said, it's furthering my knowledge on a subject mostly unknown about within my organization. Someone said, these conversations are vital for people supporting older people who are part of the LGBTQ plus community in care homes. Someone else said, attending these events has strengthened our support of services we work with, and we have shared our learning to the independent sector. And lastly, networking with new people and learning about new initiatives, hearing life stories, feeling validated. So you can see that it had an impact on quite different types, both personal and professional, but really exciting to see that people feel like they've taken away something from attending these. Then the third way that we're supporting providers was by co-designing a new resource. So co-design refers to an approach of designing solutions or resources in which community members are treated as equal collaborators. So I was not, as the lead researcher, the person making the decisions. We came together as a group and collectively designed this resource. And the group included 4 older LGBTQ plus people, and 4 care home managers. So we really wanted to represent both perspectives to ensure that on the one hand, you had the lived experience of older LGBTQ plus people and what they found important to be included. And on the other hand, the care home managers, who were really helpful in telling us what would work well in practice, what wouldn't work well, and how their workforce would take in information best. So there are already resources out there on LGBTQ plus inclusive care and also in care homes, but they're often quite lengthy and academic-y. They're not necessarily something that you print out and use on the front line in the care home. So we wanted to design something that was really action focused, that really focused on the sort of do's and don'ts for providing LGBTQ plus inclusive care, and really on the how rather than the why. And I wasn't prescriptive at all in what this resource would look like. So we came together as a group 6 times over 6 months. There were 2-hour online meetings. And what we came up with was completely a product of the group together. So we have designed a Z card for use in care homes. You may wonder what a Z card is. I didn't know either until I did this project. It's in the right corner of the screen. You can see a sort of card that folds into a credit card size, but then you can fold it out as a sort of map. And I'll hold one up to my webcam. I don't know if you can see that a little bit, but this is the one that we designed. I'll show you a little sneak peek as well on the next slide. So it's something that people can really easily carry around. They can put it in their uniform, they can put it in their lanyard, they can put it in induction packs, have it on reception counters. And it includes very actionable do's and don'ts on how to provide LGBTQ plus inclusive care. That's on one side. On the other side, we have a poster that shows an inclusive care home and includes quotes from the people who worked on the co-design. And the quotes include information on what it sort of feelings about what it means to people when they receive inclusive care. We also have a complementary video that presents the same content, but then in an audio-visual way for people who prefer to listen to content. And we've also created a logo indicating commitment to LGBTQ plus inclusion. So the resource has not been launched yet. We've only recently received the printed copies. The Z card will also be available online. And we're launching the resource officially on the 11th of September. You can see the QR code here for the launch event, and it will be freely available. So we have a limited amount of physical copies, but it's also available online. And we're working with local authorities and partners like the Outstanding Society to make sure that this resource spreads across the country as much as we can. So here's a little sneak peek. On the left side, you can see part of the poster. So one of the quotes, for example, reads, each welcoming gesture, every moment of understanding, and every act of respect provided me with a feeling of belonging and not just fitting in. And on the right side, you can see some examples. So this is just a tiny sort of screenshot of part of the Z card. I didn't want to give it all away because it hasn't been launched yet. But you can see some of the tips, for example, here it says, in brochures and on your website, include visible imagery of the LGBTQ plus community and mention explicitly that the care home is LGBTQ plus inclusive. Or another example here is use inclusive language when referring to people's loved ones. Understand that relationships may look different. So yeah, we're really excited to launch this. And this is also the part of the project that Martin has contributed to, alongside the fantastic group of others. And we had some questions for him, but Martin is going to answer the questions for the two projects together after Jason has presented. But we'll chat a little bit about how it was to be involved in the co-design process, how it was to work together as a group of older people, older LGBTQ plus people, and a group of care home managers, and what Martin thinks or hopes the impact of the Z card will be. So we'll come to that in a minute. Then to finish with some early recommendations, what can you do? Focus on building relationships with local LGBTQ plus organizations. They're often the experts that you can really collaborate with. Make sure that you provide consistent lived experience-led training to staff on LGBTQ plus inclusion and its relevance to care. Also recognize that intersectional minority identities may have unique experiences of inequality and discrimination. So for example, if you're both from a minority ethnic group and LGBTQ plus, you may have a unique experience of inequality and discrimination. Make sure you open up the conversation. Often people, as I said in the beginning, find it awkward to talk about these topics, but it's much more important to sort of break through that and open the conversation than to just keep avoiding it. Be aware of your assumptions about residents and colleagues and try to actively not act on them. Be explicit and specific about your and your organization's commitment to LGBTQ plus inclusion. Keep an eye out for the resource launch, and make sure that you, as an organization, collect data on sexuality and gender identity because without that data, you cannot monitor how inclusion is going within your organization. Just a slide to recognize all the fantastic people who supported this and work on this. It's not just me, it takes a village. So thank you to all these people. And here are my details. If anyone wants to contact me, I'm always very happy to be contacted to chat further at the project.
That's great. Thanks, Jolie. I think it comes straight over to me after that point. Great. As if we had planned this, these two projects work simpatico. So there's quite a bit of crossover that I'm hoping you'll be able to see and be interested in. So I'm just going to start my slideshow so that you can see it. And I hope that's viewable. Jolie, can you give me a, there you go. Okay, good. These two projects do link quite a bit. So I'm going to skip over some of the stuff that Jolie's already talked about. And Jolie and I have collaborated on a couple of different projects because our research agendas sort of align. This is funded by the NIHR School of Social Care Research, which means that the views are the study's views and not their idea. You can see the research team there. Of course, the cast of characters across the top of it, which included opening doors before they closed. So the aim of the study is not exactly the same as Jolie's. So where her project looked at care homes, the LOASCA study specifically looked at people that were undertaking social care assessments of older LGBT people and trying to figure out how they engaged with sexual orientation and gender identity. So one of the things that we want to know about when we think about these is what's already known, and some of these Jolie's already talked about, but there is an increased demand on social care to develop inclusive services. But the top right of your screen, the purple box, is one of the ones that I just want to spend a couple of seconds on. So importantly, services are required to collect data about gender and sexual identity, but it's not always happening. And in fact, a review by the Office of National Statistics found that less than 2% of councils were collecting this, and I'll talk about why that's such an issue as I go through the presentation. This study concluded earlier this year, so what we're talking about here are the findings and the recommendations and further information. What are the outputs going to be looking at? There have been some accusations, so this is now in the second tier of content there on the screen, that social work and social care can be sexuality and gender blind, so that it misses these as particular issues. Jolie mentioned the importance of historical experiences for older LGBTQ plus people. But also that LGBTQ plus older people are less likely to have familial support than the rest of the general population. And the importance of that is that as we become older, there's an assumption and an expectation from services that family will or could possibly step in to play some part, regardless of how much that is. Jolie mentioned about the concern on the bottom rung there about being concerned about going back into the closet. And we have a variety of different reports around from older people that say that they went round their house and removed things off the walls so that when the social worker came to do an assessment on them, that they couldn't identify, that there was nothing that gave the gay away. And that is out of concern that the assessment and the professional is going to be discriminatory, not out of shame for their identity. And I want to be really clear about that. So there is a concern that older people have, not all, but we're talking about a general sort of running statement amongst many older people, that when they first engage with social care, because they may never have had contact with social care across their life, that there's a concern that they're not going to receive as good a service, that people are going to believe that, or to have beliefs that might run counter to this. And so there's some sort of a conversation that we need to have with older people to assure them of the type of services that they can receive. Also, one of the points down on the very bottom right-hand side of the screen is that LGBTQ plus older people often seek social support from LGBTQ plus specific groups. And social care, and as you'll see in the later part of the presentation, has a gap in understanding what those groups are, so then can't necessarily connect them to these services. So the study was a large 2.5-year study. It had 3 case sites across the West Midlands, and we used a variety of data collection. And there was a huge mountain of data that we collected that included a professional survey that went out to all of the staff that undertook adult social care assessments and contributed to those across adult social care across the 3 sites. We then undertook interviews with social care assessors, so that included social workers, as well as people who undertake social care assessments, like some OTs and some other people that were called family support workers or other sort of definitions like that. We also looked at case files. So we looked at anonymized case files from each one of the local authorities. And we attempted to get these to be sort of split half and half between LGBTQ plus and non-LGBTQ. And we were unable to do that. And I'll talk about some of the implications why. We looked at organizational documents, and those included training, EDI policies, things in relation to documents in relation to strategy documents, anything that related to working with service users in the guise of attempting to complete the social care assessment. The focus for this study has been on the professional side of information, whereas most studies have looked at the service user experience, but there's been a gap in relation to what the professionals, why professionals do what they do, what it is that they undertake, why they're thinking about it. There is some information around service user experiences, but we need to improve that. So we used as a corroborating set of information, service user interviews. And again, we had significant trouble trying to recruit. Our goal was to recruit people from within each one of the case sites, and we were absolutely unable to do that just because there weren't enough people that the local authority could identify. So we had to widen that search much more broadly and then have a talk. We also included carers as well as people that used social care services. It was a collaborative project, similar in some respects to Jolie's. We had 8 PPI co-researchers that we employed on the project, and Martin was one of those. And we can talk a little bit later on about his contribution and his experience. But in essence, the PPI co-researchers were people with lived experience of either delivering or receiving social care. So some former social workers, some people that have experienced social care. And they all identified as older and LGBTQ plus, and they worked across the study, including design, data collection, data analysis, and then they're now involved with us on these dissemination events like Martin is today. So just to give you an understanding of the 3 different case sites, we deliberately selected them to differ in relation to their size, the ethnic diversity, the amount of the population, and what the setting type was. And you can see there some of the sort of ways that they predominantly differed. So for example, one that we're calling Urban Town was a densely populated inner city council that had huge amounts of ethnic diversity, substantial number of adult social care users and staff, and had a relatively low percent that they identified as LGBT residents per population. A small suburban council was next with a mid-range of ethnic diversity, and again, it had a disproportionately low number of adult social care users. And then a rural remote council that was large geographic, but had very few, comparatively fewer people in it, and a very low ethnic diversity with a significant proportion of white British population in the area, and it had a mid-range number. And this will give you a sense of how we selected these sites. What was interesting, though, was the largest of the councils had over 10,000 people that it worked with under adult social care. And they could not identify even 5 people that were LGBT according to them. Now, I wasn't asking to get contact to who those people were. We were just talking about numbers here. And they were unable to do that. And so what that points to is the challenge in being able to identify and then to record that sort of information. So the key findings, and I'll talk in a little bit more detail about these as we go through the various different types of data. LGBTQ plus people are often missing from policy considerations and staff discussions. And we're talking here about at the council level. We're not talking national policy in this context. So we're talking about EDI strategies. We're talking about working with older people, a whole range of things, but it didn't come into there. There were significant challenges with data collection about service users' sexual orientation and gender identity. My point about, only able to get 5 people out of over 10,000 is a clear inability to both identify and then record that. And there's a variety of reasons and issues for that. But the fact is that the central government expects this, and then we have to try to figure out how to do this in a way that aligns with service users' wishes, but also addresses our expectation, just like we would for ethnic diversity, disabilities, and age, for example, as other forms of identity. We found a double bind of professional and service user anxiety. So both individuals in a social care assessment were anxious about LGBTQ plus identities. So professionals were unsure about how to raise it, what sort of language to use, and how to discuss it. They may want to do that, but they didn't want to. They often talked about not wanting to offend a service user. And the service users that were LGBT told us that they were worried about getting a poor service if they told the professional that they were LGBT. So what this means is that in those social care assessment discussions, both parties are not acknowledging that there may be minority sexual orientation or gender identity, some of which might have an influence on the type of service that the person might want or the type of needs that the person has. So for example, around not having children and what that means for options as they age. Social work staff, though, told us repeatedly across each one of the sites and in a variety of forms that they wanted greater knowledge about how to apply LGBTQ plus issues in their practice. So they wanted to know what language to use. They wanted to know how to approach the topic sensitively. They wanted to know what the needs were of this population, and they wanted to know how they could think about them in relation to assessments. Now, I'm going to skip over this quite quickly because there's some more meatier information in the professional interviews. But in essence, from the survey findings, that there were some groups that were more heteronormative than other groups. And that's not a surprise. We find that repeatedly across lots of professional groups. So social work and social care is not alone in this. Men in this context had more heteronormative and essentialist beliefs than women did. And that, again, is found in other studies. But we also used a comparator here that LGBT participants held less heteronormative beliefs. Again, something that we would expect from this sort of study. Some qualitative statements here from people. So the top left talking about the fact that in 27 years, I've never seen any training specifically in this area. Or secondly, the common refrain that we heard was that I don't need to think about sexual orientation and gender identity, that everybody needs to be treated equally. And that next quote there talks about that. I don't think there should be any barriers. Everyone should be treated equally with respect to regardless of sex and gender orientation. And then the last one was also another running theme that we had where they professionals talked about feeling very uncomfortable about asking in relation to sexual orientation and gender identity. In essence, how should we approach this without possibly causing offense? And there's an example here on the right-hand side of the screen of a positive statement from a social care worker that I want to make sure that we identified that there were some practitioners that had really developed a nuanced approach to this. So as social workers, it's our vocation to create the core conditions for therapeutic discussions. Supporting people to discuss their sexual orientation and gender identity is an essential part of this, and it's often overlooked. When we leave this out of our assessments, we lose half the story and miss our opportunities to validate and respect a person in need. So moving on just briefly to the professional interviews, I'm only able to pick out some of the key ideas. There's a wealth of data underneath of each one of these. Most of the people that we spoke to were unable to identify any LGBT service user that they'd worked with. And we saw lots and lots of phrases or statements like this, so that I haven't knowingly come across someone who's LGBT in practice. And our practitioners had quite a wide range in experience levels, so some of them have been qualified for well more than 10 years. And one of the conversations I had with one of the local authorities was, if you think that an adult social care worker might come across, say, 30 to 40 people in every single year that they're assessing or working with, and that's a very that's a significant underestimation. And then we multiply that by 10 years, you're talking about what, 300 people, 300 to 400 people. So we would expect at least roughly around 10% of those. Again, we're talking about 30 to 40 people that they should have come across. So not knowingly come across any of those, again, is a significant sort of omission on relation to being able to identify. There was a significant fear of saying the wrong thing, which I've mentioned. I didn't want to say anything wrong. And then this last one is a repeat from the survey about treating everyone equally. So this last quote here is a statement from a social worker that said, I don't ask the question because I think it's irrelevant, so I don't ask it. It doesn't matter what your identity is as to how I do my assessment. I would do everybody equally and fairly. And I think this sounds a bit like, I'm a social worker by background, and I've been doing this, I've been a social worker for a long time. And there was a robust discussion in the profession in the early 2000s around discussing around ethnicity and assessments and the challenge for that. And the same thing is in relation to here. The impact of not asking these questions or thinking about them means that our assessments aren't holistic and engaging with the entire person. Social workers and social care workers did feel able to raise these issues with management, but that they hadn't really had cause to do so. But they did ask for more LGBT training, and there are some evocative quotes there around that. So I'm just going to pull together some of the other content for your information. There's lots more of this data in the outputs, the reports, and the papers that I'll be talking about. So there, in the case files in particular, there were missed opportunities to discuss sexual orientation and gender identity, so that it appeared that social workers and social care workers didn't follow those things up and didn't ask questions, even when service users would raise the fact that they were LGBT. It wasn't followed through, and there wasn't a further discussion about it. The forms often used people's relationships as a proxy for identity. So if people were in a same-sex relationship, that was identifying them as LGBT. Whereas if they weren't in a relationship with anyone, then there wasn't an assumption that that needed to be talked about or discussed. In the documents and so for example, the strategies and other things we looked at, trans identities were often missed from strategy and plans, and LGBT people were usually unspecified, and they were included in a broader set of EDI, often just listing the protected characteristics with no further engagement with what this part of the population might need, how they might need to be specifically looked at. And again, we're talking about 10% of the population as a sort of rough guesstimate. And so we would expect something more developed to be connected to this. In the service user findings, we heard from service users that said that their professionals needs to be better in understanding how to connect with LGBT services, both local and national. And lastly was a need for a better awareness of LGBT service users. And that links to what professionals were saying about the desire for better information in relation to that. So the implications from this study, some of those align with what Jolie was talking about earlier, but we're talking about a much greater emphasis on data collection. In particular, asking service users in all assessments around sexual orientation and gender identity, because the fear of offending people isn't a good enough reason not to be asking. And that aligns significantly with what Jolie is saying. And there are people that get offended about all sorts of questions that we ask. And my argument is that we as social care workers have a huge amount of knowledge and expertise around having challenging conversations. And this isn't really the most, or typically the most challenging conversation that we would have in these. We want to talk about supporting access to current knowledge, and that might be training, which is the next issue. We're suggesting that training on LGBT issues and LGBT content should be mandatory and coherent, and it needs to apply that training to practice. because of those gaps that we're talking about. Ensure the environments include pro-LGBT symbols. That includes lanyards and content and other things like that, because there is evidence in research, not my research and the ones that we're talking about today, but that service users look for that when they come into an organization, whether it's a local authority or anything else. They're looking for something that tells them that their identity might be supported. And that might be having somebody that has that as a practice area of interest or anything else. Ensure that staff are aware of local and national LGBT service organizations so that they can link them to them. So, for example, there might be an LGBT center or there might be an LGBT group in the area to connect them to, as well as some national ones that might relate to more specific identities. And then to ensure that sexual orientation and gender identity related topics are included in practice, and particularly in EDI discussions and policy briefs. So that means that just like we talk about ethnicity and disability and age and a whole range of identities, sexual orientation and gender identity needs to be a part of those conversations so that we support those people that are undertaking assessments to be able to think about these in relation to how they're undertaking their assessments. I'm getting close to the end of the presentation, and after the thanks and other things, Martin is going to come up and talk about his contributions. But one of the last things I want to talk about is the outputs that came out of this study. So we're really proud of the work that we did with our co-researchers and the other people to develop these outputs. So there's a SKY, some of you might have come across that. That's the Social Care Institute for Excellence. There's a knowledge repository, and it's not just about this study. It is about a whole range of information in relation to LGBTQ plus older people and specifically social care. And there's a link to that coming up. The coolest thing I think I might have done across my career is the graphic novel, and there's one of the set of panels there on the right-hand side. And that we worked with a fabulously talented graphic artist in order to pull this together. It's a series of 3 stories that don't use much text and deliberately represent the story in a series of images to help people understand how talking about this might be important in relation to gaining social care access. And it's predominantly targeted towards service users, but we're hoping that councils will be using it in some of their training. There's an animated video that helps social workers and social care workers think through the challenges and offers a couple of options for when these issues come up, how they might want to respond, and what would be a positive and a more challenging way to think about this. There are a series of briefings and academic outputs, most of which are located on the SKY repository as well as the project website, and you can find them there. Thanks very much. The research fellow that was key on this project is Dora Yandrick, and there's a couple of QR codes there for the SKY Knowledge repository and the LOASCA website. And I'm just going to hand over to Martin now, and this is a series of questions for Martin to be able to answer about his experience. Martin, are you there?
I am. Can you hear me okay?
Absolutely.
Thank you. Well, I'll tell you what, I am absolutely blown away because it's the first time I've heard 2 complete presentations from the 2 projects together. And I'm thinking, have I been involved with that? That's amazing. That's, to me, it's like going up to Mount Everest and coming back down again and saying, we've been up there and down there. 2.5 years ago, when I first got to know about the LOASCA project, when we had a little bit of problem recruiting people, I remember going into, I went into my mom's care home, and my mom's 94 and she's got Alzheimer's and dementia. And I felt really nervous on knocking on the manager's door to just to talk to her about what do you do in the care home about LGBTQ plus. And when I overcame my fear, suddenly she was so wanting this kind of stuff. So I've written a few things down. I've got 3 or 4 minutes, and I'm thinking it's robust, it's researched, it's auditable, and it's not some gay guy whinging about stuff. You know, this is hard research, and that's what really attracted me to the 2 projects, particularly the outputs, because I've seen so much research in the past where it's fantastic research and then it's popped onto the shelf. And that was why I interrogated Jason and Jolie for, you know, what's going to happen to this stuff. So really quickly, I put this together this morning. If it comes up, it's a co-researcher's experience journey map. So I put this together, and here down the left-hand side this is the process we went through on both projects of awareness, consideration, onboarding, participation. And these were all the touch points. And then this was all the pain points on the right, where, oh, I'm uncertain about what to do. What are we doing about this? What are we doing about this? And that. And these were the emotions which came up for me and other co-researchers. And I'll just come back in the room if I can. Yes, here we go. And I tell you what, the biggest thing for me which made these two projects work, besides the academic research, was the people in the back room, how they supported us co-researchers. We got paid a small sum of money for when we did things, and that was taken care of. If we had problems with the HR department of the university, it was taken care of. Absolutely fantastic. And I'll be quiet now.
That's brilliant. Thank you, Martin. Sorry, go on, Jolie.
I wanted to say we can talk about this for hours. I think it's been, and I think I can speak on behalf of Jason and myself, that it's been fantastic to have you and the other co-researchers. You can see there's another one here. It's been so fantastic to have them involved, and the project wouldn't be the same without your contribution. So.
Brilliant. Thank you everyone for your contribution today. So we've got quite a lot of questions and 10 minutes left, so I'm going to try and pick out some of the ones. And so Claire has asked, this is probably well, for anyone that wants to answer it really, for statistics, older queer people often don't feel safe to volunteer their true gender or sexuality. How can you reassure people needing care to fill in surveys honestly?
Do you want to go first, Jolie?
Yeah,
Do you want me
it's
to go?
almost like, I think it's a cycle, isn't it? Like, if the environment isn't safe, then you're not going to disclose, and if you're not going to disclose, then people are not going to know that, because a lot of people think that older LGBTQ plus people just don't exist. They say, oh, we've never had one never had anyone in our care home. So I think in both projects we mentioned some of the things that you can do to make your commitment to LGBTQ plus inclusion explicit, and you need to make sure that that's not tokenistic. So don't just put up a rainbow flag and think that's it. You really need to think about how you then apply that to your practice, and how you and your conversations, and how you care for people as well. But I think Jason put it really nicely, that a lot of people, and that also goes for younger people identify as LGBTQ plus, you look in you're vigilant about your environment and look for clues. So if you see signs that could indicate that people are thinking about this commitment, then I think you're more likely to disclose. And in terms of larger national surveys, I think it might be helpful to emphasize why that data is being collected, so that people understand the reason behind it and see that it's for a good purpose. Do you want to add anything, Jason?
Yeah, the other thing I just wanted to say is that our work doesn't necessarily relate really to national surveys, and we would be talking about the interpersonal conversations that are happening between care workers and professionals and a person who uses services. And in those contexts, that individual relationship can be mobilized to make the older person feel safer in order to talk about this, as well as discussing why it's important to even know this information. Because having a conversation with somebody and saying, we want to know this because we think that there might be things that we could help you with, or you seem isolated, or all of those other sorts of things could be some of the reasons.
Brilliant.
Can I throw something in the pot there, Kat?
Please do.
Well, I did a quick survey of what are the types of things in a restaurant owner could ask about whether you're vegetarian, pescatarian, whatever. And there was something like 25 sets, vegan, halal. And I'm thinking 30, 40, 50 years ago, I'd be looked upon as a nutcase if I said I was vegan. So it's the same kind of trajectory, you know, we're getting to, where it just becomes normal place. Well, I'm a vegan, I'm a doodah, and it's all taken care of.
Brilliant, thank you. There's quite a few questions asking about the two different projects, about sort of next steps and follow-up plans. So I don't know if either of you can touch on that.
You go first, Jason.
So I've just put up the Sky resource underneath of one of the other comments, and that's one of the things that we're going to be continuing to work on and pulling through from various projects. We have a further extension of this that we're talking about doing, but we need to get through the dissemination phase first. And there, with such a mountain of data, there's loads of things that are going to be coming out from it. We've already done a few academic conferences with this project, and so we're expecting to do some more practitioner-focused ones. We've done some, but I'm talking to like the principal social worker networks and a couple of other things about what we can do with this data. So that would be what I would be saying would be happening next. The practice-focused outputs are already generated, so those should be out there and available. Jolie?
Thank you. So we have just received the physical copies of the Z cards. I'm currently really busy with disseminating them, distributing them across both the region I'm in, and hopefully they'll also be part of the Care Show in Birmingham in October. Any follow-up work, I'm hoping to do some more evaluation of the impact of that resource on how people in care homes find it to use it, and if it helps them in their practice. And I'm also awaiting a large grant application looking at LGBTQ+ inclusion in home care, so to sort of extend the work to a different care provider, because there's an incredible lack of data within home care, and I think a very interesting, important context to look at as well, because you don't have the social control that you maybe have a little bit within a care home. So hoping to receive a positive response about that this summer. Fingers crossed.
Brilliant. I've done a bit of work on home care research as well, and they seem to be the poor relation to everything. There's like health and social care, residential care, and then home care. So that would be great. That's good to hear. I think probably just one more quick question. So Verity's asked, do you have recommendations for how to ask about gender and sexuality in a person-centered way at assessment? Social workers mentioned that family members being present for the assessment may add to the general discomfort around disclosing this. So that's quite a nice practical note to end on. So any advice for that one?
Yeah, so we generated a set of questions and then tested them with people with lived experience, and we came up with the idea that starting with the sort of blunt question about what is your sexual orientation, what is your gender identity, is unlikely to be useful in this context. So we suggested a more sort of nuanced way about approaching it, or sort of oblique, where you talk about a range of identities and you talk about the person's life, which should be a basis for a social care assessment anyways, and then saying, as a part of this, one of the things we need to know about is about the entire person. And I'd like to ask you about your sexual orientation or gender identity. Are there, do you identify as anything in particular? It'd be that sort of an approach that we would recommend, rather than a sort of a formulaic approach that says, what's your ethnicity? What, do you have any disability? That sort of approach tends to be, particularly for this issue, tends to put people very, put their backs up, and tends to encourage quite a lot of offense.
Yeah, we had similar, I think, ideas within when we talked in the co-design group for the Z card around making it part of a conversation about what and who are important to you, and just making it part of, as the whole person, rather than just listing a set of questions that can come across as intrusive. Yeah, right.
Brilliant.
And
Okay, there's loads more comments and things. I suspect we could probably be here for ages, but we are going to draw it to a close so we can finish on time.
Can I
There's a
just
lot
say,
of
Kat,
yes,
that
please do.
if anyone wanted to sort of had big follow-up questions, I'm very happy to be contacted. I think we both put our emails on the slides, so just to say that.
Thank you. Yeah, and as well as that, Jason and Jolie perhaps will hopefully send me sort of slides and maybe links to any of the materials and things. There's a lot of questions about where you can get access to any of the materials they've been talking about. So afterwards I can send out an email with the slides and any links to any of the stuff that they've been talking about, so you can all access that. And I think we're all quite happy to be contacted for any other questions and follow-up things. So I'll just finish by saying thank you to everyone who's come today, and thank you to our 3 speakers. If any of you who have come who aren't on the mailing list and would like to be for any future events, get in touch and we'll pop you on the mailing list. And also, if you have any other topics or things you think would be useful for future, do let me know. Anybody want to add anything? You've got 1 more minute.
Just thank you to Martin for joining the presentation.
Thank you folks.
All right, brilliant. Thanks a lot, everyone. Take care, have a good rest of the day,
you.
and thanks for coming. Bye bye.
Bye.
All
Bye.
right, thanks.